My name is Stephanie Covell, and welcome to A Mindfulness Experience with Access to Integrative Medicine Health Institute, the GW Office of Integrative Medicine and Health, and the GW Resiliency and Wellbeing Center. AIM is the first 501c3 nonprofit in the Washington, D.C. metro area to provide integrative medicine services to patients who face financial barriers to care or terminal illness. The office is a global leader in integrative medicine, focusing on the professional development and community outreach. The center takes an evidence-based, whole-person approach to the health, wellness, and well-being services it provides to the GW School of Medicine and Health Services faculty, students, trainees, and staff. Today we have with us Angela McConnell, Ph.D., also known as Dr. Ange Mack. Dr. Ange Mack is a healthcare consultant, educator, and advocate who bridges the gap between women's needs and physician support, drawing on 30 years of experience across medicine, integrative health, and leadership, including work in the military, government, and nonprofit sectors. Speaking at hundreds of integrative medicine platforms worldwide, which include the GW University School of Medicine and Public Health, the Department of Defense Centers for Excellence for Psychological Health and Traumatic Brain Injury, and the American Case Management Association. She now focuses on education and empowering women through evidence-based education on perimenopause, menopause, and midlife health. Welcome, Dr. Ange Mack. And we'll start things off with Dr. Kogan.
Hi, everybody. Welcome to the Friday of Good Showing today. So I got updates on infections. First, let's quickly Ebola. I think a couple of weeks ago when I last mentioned it, I spoke too soon. Sounds like the epidemic continues on the rise. It's now hitting heavily Congo. So I would say that if in the past I was suggesting if you had plans to travel to South Africa, you kind of reevaluate and sort of consider not going. I think this continuous situation evolving, so stay tuned. I think the best way to look at this is keep an eye on CDC recommendations as to sort of what's the current situation, and if you're my patient, obviously ask me questions. So unfortunately, I don't think that for various reasons this epidemic will be arrested the way I was thinking. I think unfortunately it's going to keep growing. It's only in part due to our political situation. There's lots of other moving pieces. So I think this to be determined as to how this is going to occur. Now, on the other hand, the COVID, of course, is much more predictable. So we're beginning to seeing a surge as expected, similar to last year. So what does it mean for you? Well, I don't think it changes anything. Don't get the vaccine for sure. Don't even consider it because it's going to be total waste right now. It doesn't work. The current shot is just not going to cover the strain that's circulating. So wait until the new one comes out, which means that will be hopefully as last year, sometime in late September, early October. The moment it's out, you probably should get that one. And again, only once a year. Now, there are some interesting news. So first of all, the Paxlovid is back on the map. Last couple of times when people ask me, what about Paxlovid? If you do get the COVID, should you take it? Should you not take it? The idea was, no, don't take it. The newest study that was just published a couple of weeks ago actually showing, well, yeah, it doesn't change as any outcomes from perspective of severity, meaning it doesn't decrease hospital admissions, it doesn't decrease mortality, but turns out it significantly decreases length of the disease by about 24 hours. And actually 24 hours is quite a lot on average. So if you're worried about, I don't know, you have some event coming up, you want to travel somewhere and you got sick, and so I think actually Paxlovid is back on the map. And then there's the newest medication called Xacova, Xocova. So I'm going to put that in. And this is something that we're going to use rapidly, increasingly because of the safety and efficacy. This is way safer than Paxlovid. There's no real known side effects outside of allergies and then maybe some upset stomach. This is actually not the treatment drug. So this is drug that's in Japan used and the rest of the Asia used for both treatment and for the prevention. In US, feds approved it only for prevention. So you have to initiate it within 72 hours from the exposure. It is a reasonable choice. My sources tell me that it's covered by every single insurance. So you could contact your physician if you're concerned about exposure. I think as of today and for the next few weeks, I don't think that there's any issues. I think the surge is going to continue slowly first until it peaks, and then, of course, it'll be around quite a bit. So I don't think that you're going to need to reach out to me or to your provider in the upcoming weeks, but this is more towards I think, after Labor Day. Okay, vaccine is not okay to get. Don't even consider. There's no point. Cecil, the current vaccine doesn't cover the current strain. It doesn't cover it at all, meaning it's not decreasing your chances of getting it. There's no point getting it because the prior booster is already protecting you enough from complex illness. Adding another booster right now is 0 cents whatsoever. So don't know. Wait for because if you get it now, you're actually going to have a trouble. Because if you get it now, then you shouldn't be getting right away the next one that comes out, and that's the one you should be getting. You should be getting the vaccine that's going to come out in the September, October that will include the current strain. So this is very important. Even if you're traveling in the next couple of weeks, do not get the current vaccine. Understood? Okay. All right. I see Phil had a hand. What about flu and RSV vaccine? Well, what about them? There's no flu vaccine right now. There's no flu right now. There's no point even talking about it. So RSV is difficult. I do not vaccinate against RSV anybody unless you are my patient and unless you either have COPD or you have some specific lung disease. I do not believe in this vaccine for everybody, even for people who are older and immune compromised. The only situation where I give this vaccine is when I'm really worried about a person's respiratory status. So if they have a severe asthma, if they have COPD, if they have other lung conditions that worry me. Everybody else, there's no data. Basically, even if you're 75, 85, 95 and you get RSV, it will look like flu. Actually, it will look lighter than a flu. It will look more like a acute respiratory cold. The difference is that if someone has a high risk for complications, and how do you tease that out? Well, that's how you tease it out. So I disagree about RSV statement of feds. The feds say everybody over 65 should get RSV. I disagree with that. I don't see any reason for a healthy 65-year-old getting this vaccine. No, current strain it's the same strain. I don't think it's less harmful. It's not very severe cases as I guess we got really lucky that as COVID kept on mutating, it actually instead of becoming more severe, it's becoming less severe. It's just becoming more contagious. That's why there's no expectations that COVID ever going to leave us. It's just going to become an annual flu like we had annual flu for many, many decades. So I think the COVID's going to be just like that. Hopefully that answers that question. Surprised nobody's asking about this Xacova yet, this medication. A lot of people are gonna probably ask for it in upcoming period because it does seem to be an interesting choice. Because preventing symptoms will make a lot of sense for people, especially if let's say you have a situation where you got exposed and you have something coming up, like you're going to travel somewhere, right? In the past, we would isolate and sort of just wait until whether you have symptoms or not. You could there was this idea of getting infusion of antibodies, but they're very expensive. They are very toxicity prone. There's a lot of side effects with those infusions, particularly severe allergic reactions and high blood pressure. But with this one, it seems to be quite benign. It's covered by insurance. It's not very expensive, relatively speaking, and it's non-toxic. So okay, cyclist paralysis status. Yeah, it's still around. I talked about this last week. I don't have any new updates, Emmy. I think keep an eye. I particularly said that it's supposed to be self-resolving in most people, but if you get pretty bad diarrhea with fever, with nausea, vomiting, and it's not getting quickly better, I would say quickly meaning 24 hours, 48 hours, yeah, then you should call your provider and get a prescription. The drug is Bactrim. It's a common antibiotic, easy to get, very low cost. should take care of it if it's not going away. And it may not. There are some people it could stick around for a while. And you would know. So if you had a acute diarrheal infection and it kind of lingers and it's been now weeks, then you should probably check. The test is very easy and just run the stool analysis for this infection. It's not a bacteria. It's a parasitic infection, protozoa to be the exact. It's not quite a fungus either, so it's a single organism. The closest organism to it is a giardia, so traveler's diarrhea. In fact, some people will bulk cyclosporiasis into the traveler's diarrhea, which is not correct. Cyclosporiasis is basically a fecal oral contact, and it's generally seems to be more like vegetables that have not been properly tended to. Good questions today. All right, I do want to give everybody a quick heads up. Oh, thanks so much, Steph, for putting beating heart moment in there. I would like to share one upcoming event with everybody. Let's see, how do I do that? 1 second. Get to the calendar here. So on a September 25th, we will have an upcoming open house, Recode open house. So what I'm gonna do is I'm gonna give you a link. I'm gonna remind everybody, Recode is our reversal of cognitive decline program. And this time in September, we will have a program about hormones and how addressing hormonal health is important in prevention and treatment of cognitive decline. So I'm going to give you a link in 1 second. Right, you can put that, you can copy paste it, put it on your calendar, and we'll see you on the 25th. Okay, so I'm at 15 minutes. Let me take a couple more minutes before I pass it on to Angela. Should lettuce be avoided? No, I would wash it. There's actually still unclarity as to exactly the source of all this. So there's some idea it's coming from some jalapeno peppers from Mexico. I don't think you can't avoid eating all the vegetables. So don't go crazy. Wash everything well. I think that's the best I would say. Now we talked about like washing, right? So I actually did a little bit of search last time after the meeting. Believe it or not, that's much more complicated topic. But there's one way you could do washing a bit more effective. Instead of just running the water, throw the vegetables into the water and let them sit for a while, soaking. And that often, believe it or not, works even better, especially if the particular vegetable has a lot of pores, because the bacteria slowly will kind of gradually fall off and into the water, dilution effect, I guess. And you just pour the water. You can soak it a couple of times too. You know how we soak the beans? So you could do that. You just don't need to soak for overnight. You can soak it for probably 10 to 20 minutes and then rinse it again. You want to soak it time, fine, and then rinse it, and then it's ready to be eaten. All right. Okay. If there is no more questions, I can pass it on to Angela and give people one last moment. Let's see. And again, as usual, if you're my patient, you have something for me personally, please do stay for after the meeting so we can take care of your personal issue. Angela, thanks so much for being here. It's wonderful. It's been a while. I think last
Yeah,
time it's been quite a while, so we're so excited you're here. Thank you.
wonderful. Thank you for having me, Stephanie. Thank you for the introduction. As Stephanie was saying, I've been in the integrative healthcare field for about 30 years now in different capacities. In the beginning, I was working with healthcare providers who were trying to transition their practice from traditional medicine into more integrative, whole person, looking at prevention and lifestyle behavioral changes. So I've done that. I'm also 22 years retired military. So I have that background, and I taught for George Washington in their integrative medicine department for a couple of years ago. So it's so nice to be back and to see everyone, and it's been a while. My focus in integrative healthcare these days, over the last 3 years, is specifically in the area of women's midlife health. So I'm focused on perimenopause and menopause, and that means hormones. And Stephanie's going to help me with the slides because I cannot see them. So Stephanie, if you could go to the second slide. And essentially, it's I want you guys leaving with information on what is perimenopause, what is menopause, how it affects you. I always say that if you're a woman or if you know a woman, like your mother, sister, friend, you're going to get something from this presentation. It's information that many people in general don't know about, and it's also information a lot of the physicians are not trained in yet. So we're going to define what perimenopause and menopause is, and for you all out there, what you can do if you recognize potential symptoms that may be related to hormone depletion. So Dr. Kogan, I'm interested in your September presentation that you just mentioned focused on hormones. It's just an incredible system in your body that controls basically everything. So it's fascinating in hormones. So Stephanie, if you could move to slide 3 where it says menopause myths. So, if in an in-person presentation, I really like to ask the audience, what does it mean when they hear menopause? And undoubtedly, someone will raise their hand and they'll say, hot flashes. Like you get these horrible hot flashes. You gain weight. I hear the menopause belly or the menopause baby, and women will start to gain weight in areas around their belly that they've never had before. So that can be very frustrating if you're eating the same and doing the same amount of exercise. But it's really much more than those things. And that's what I'm here to share with you all today. Stephanie, can you go to the next slide? What is menopause? So again, a lot of people, even myself, before I really understood it, thought it was a time in your life where you kind of stopped having your cycles and your periods. So you're going along and then maybe you're having some hot flashes and, feeling moody and uncomfortable, and then your hormones are gone. By definition, menopause means 1 year without having a bleed or a cycle. And so you're either in perimenopause, which is the time before menopause, or you're postmenopausal. Menopause is actually just 1 day in time, and that's how they define it, for lack of anything better. So when we talk about perimenopause, the time before that menopause date, this is the period that I really want to talk to you all about. So even if you're not in your 40s or 50s now, even if you're kind of through that menopause stage, you may know people, women in their 40s that could start experiencing symptoms. And these symptoms, and I'm going to show you a whole list. I totally break the presentation slide rule of like 3 bullet points, but in a slide or two, I'm going to show you a whole list of symptoms that could be related to perimenopause. That's when your estrogen starts to go down and fluctuate along with your progesterone. So instead of the normal cycles that a woman has, like every 28 days or so, if you cycle normally, and your hormones fluctuate normally, they start going sideways. Sometimes you'll have periods, sometimes you won't. Many women do experience hot flashes, but there's so many other symptoms and impacts of hormones that we don't normally realize. And if there's any physicians, I know Dr. Kogan, you're on, if there's any other physicians, I also present 2 physicians to really go into the depths of what these hormones are. And I won't with this audience, but you'll probably get more than you bargained for. And thankfully, Stephanie now has this presentation. We're gonna share it with you. So if you don't know all of this or remember it, you'll be shared the details. So perimenopause is when your hormones start going away. So your ovaries have so many eggs when you're born as a female, and over time those start going away. And into your 40s, you really start to feel the fluctuation. And Stephanie, could you go to the next slide, please? Estrogen, progesterone, testosterone. So why do we care? It's a natural process. Yes, it's very natural. It's very normal. I mean, every woman, if you live long enough, you're going to go through perimenopause and then postmenopause. But the thing I didn't realize, and many people don't, is that there are estrogen receptors on every organ system in your body. So what does that mean, estrogen receptors? So these receptors are used in your brain, talking about cognitive and neural health. They're in your bones, they're in your muscle, your skin. If you notice, your skin might get dry or crepeier or thinner when you get older. They're in your eyes, they're in your digestive system, in your stomach and your intestines. Your microbiomes change in those areas over time because you're losing estrogen and it can't fill those receptors, which are all the organ systems. So this is critical because we for so long just thought it was a gynecological issue. You would lose your estrogen and progesterone. You can't have babies anymore. You don't have any more eggs coming out of your ovaries. So therefore, you're kind of moving into this next transition piece in your life. What we didn't realize, it was affecting our heart and our lungs and our immune system. We were getting sicker as women. Cardiovascular disease is the number one killer of women. And those issues start during perimenopause when you start losing the estrogen. Some women feel heart palpitations and, where your heart flutters. Some get out of breath. There are many symptoms that we maybe play off to, well, I'm raising kids and I'm tired all the time and I'm working and I'm doing these things. But in your 40s, and sometimes earlier than that, in your late 30s, you can start experiencing the loss of those hormones. It's really important to, and I'm going to kind of say this throughout as individuals, and I know you get this from these presentations with the AIM Institute and Dr. Kogan. You really need to pay attention to how you're feeling, to your potential symptoms, and don't disregard them because you need to let your physician know these things. Because again, the loss of estrogen, and if you're over 50, 60, 70, all of this may have already impacted you. And we're going to talk about what we can do about that at that point, post-menopause. So bones is another big area. When you go through perimenopause and menopause, again, we lose the estrogen that impacts your bone health. And so your bone starts deteriorating. I always ask, who's had a DEXA scan, which measures how healthy or dense your bones are. And most every woman over the age of 60 or 65 has a DEXA scan. But by that point, you may have already lost 30% of your bone density. So I always encourage earliest possible bone scans and hormone testing as well. So these are also important pieces that I'm going to share with Dr. Kogan and the AIM Institute. So we have more resources available for the patients, for you all, and for the providers as well. Stephanie, the next slide. Over 500 million people in our entire world are women. So that's about 4 billion women in the world, and about half of those are in perimenopause and menopause. Why is this important? Because most of our education and training are around women who are in the maternal childbearing ages. So like 20s, 30s, now 40s. And we're focused our research on that because it's very important to have healthy moms and healthy babies. But if you look at the bigger picture, we're not really treating and assessing women that are in 40s, 50s, 60s, 70s, and 80s for these hormone depletion conditions like cardiovascular disease, dementia, Alzheimer's. These conditions the decline start right around your 40s when you start losing the hormones. So again, if you're starting to feel any of these symptoms that I'm going to describe here on the next slide, we really need to start taking notes of how we're feeling and when we're feeling these things. And you guys may journal. This may have been something that your AIM Institute, have talked to this audience about in the past, but journaling and tracking symptoms. And if you're still cycling, if we have younger women on, if you're still cycling, make sure you track your cycles, because when those start becoming irregular, there's usually something going on. It may not be perimenopause, it could be PCOS or other things that could be going on with your ovaries and your other hormones, but we need to track, we need to pay attention and be aware of our bodies. So another interesting fun fact is that most of the research over the centuries have been done on male subjects, either male mice or rodents in clinical studies, because women were thought to be more complicated. And we are, we have different hormones that are fluctuating. We have ovaries, we have a uterus, we have a vagina, we have different parts than men, but research really wanted more stable, test subjects and guinea pigs, so to speak. So most of the research over time were focused on men, and what we found is that does not translate to a woman's body. So thankfully, that's starting to shift, but we are so far behind the curve on how to look at and treat women based on the research in cardiovascular autoimmune conditions, you name it, across the board. So Stephanie, next slide. Why do we care? Why do we care about this? I'd love for like people to answer these questions and raise their hands. But I will say this one slide probably pertains to everybody here in this audience who's a woman or knows a woman. Cardiovascular disease is the number one killer of women. We always think cancer, breast cancer, and that's also a concern, but the number one is your cardiac health. And so when you get older, you start losing those very healthy hormones that protect your heart and your brain. And also with breast and lung and colon cancer, very big number two on the list of fatal killer in women. So this is why it's so important to pay attention to yourself and your hormones, right? Respiratory diseases, lung conditions, number three, leading cause of death in older women. And then interesting enough, unintentional injuries like accidents and falls, you guys might know the some of the statistics for falling. When we get older and our muscles get weaker and our bones get weaker, sometimes we tend to shuffle our feet instead of being very intentional and lifting our feet. You snag it on something, you fall over, you break a bone. 30% of the women over 50 will, if they break a bone or a hip, will not recover and they'll be in assisted living or die. And that's an international statistic, not just US. So we want to keep our bones healthy. We want to keep our muscles healthy. And I know you guys get that exercise piece as well. Metabolic diseases is also the fifth killer. And that just basically means in any other disease, potentially like diabetes, not related to cardiovascular or stroke cancers. Next slide. And please keep an eye on the time because this is where I get into the weeds of a lot of the symptoms and details. In 2023, I was diagnosed with ALS or Lou Gehrig's disease. I was misdiagnosed with ALS. I was told I had 2 to 5 years to live, get all my affairs in order. I immediately sought a second opinion, but it was about 3 months before I was seen at UVA in Charlottesville, Virginia, where they said, no, you don't have this neurological muscular condition, but we don't know what you have yet. And through about 20 different specialists, and you can go to the next slide, Stephanie, symptoms versus obvious versus insidious. After multiple specialists and me saying, hey, I think I'm in perimenopause, I'm missing periods, I'm not having hot flashes, but I'm definitely having some thinking issues and brain fog and fatigue and other things and weird cramps and stuff in my body. About 15 specialists that I saw said my hormones had nothing to do with that. It would not significantly impact. A year later, after a lot of research, because that's what I do is research, I started on hormone therapy, estrogen, bioidentical, estradiol, progesterone, and a little testosterone. Within 4 to 5 months, I had 80% reversal in all my symptoms. And this next slide that says symptoms, these are all of my symptoms. What I didn't really have were hot flashes or something very common, frozen shoulder, where your shoulder gets super stiff. And they actually call that 40-year-old shoulder in women because it happens like in your 40s predominantly. That was named by, I believe, the Chinese first named that condition, 40-year-old shoulder and stiff frozen. So I'm not going to read you all my symptoms, but I saw, again, 15 different specialists. My vision was getting bad. I had a hard time breathing. The brain fog was the worst. I couldn't drive for about 6 months. I couldn't determine what to do at a red light or a green light. That's how bad my thinking was. I had to step down from teaching at George Washington. I had to stop my consulting work for a while, and I also run a veteran nonprofit, Nova Veterans Association. I had to put all those duties off on other people for about a year when I was figuring out. So this is no joke. And if you're in this age range or even older, I'm going to talk about when you're, postmenopausal as well. Um, if your hormones are declining like they did in mine, like they just dropped off a shelf, like it seemed like in 2 or 3 years, all of these symptoms can really impact your quality of life. And my mission now is to work with women in midlife and their physicians, and actually with the state of Virginia on legislation, so women get the proper assessment and the proper treatment, and doctors aren't afraid to give them bioidentical hormone therapies or whatever it is they may need. So I will say there's a lot of mimickers sometimes out here. Maybe it's not low progesterone and estrogen. Maybe it's a problem with your thyroid. Maybe it's a problem with testosterone. So I'm not saying if you have these symptoms, you're in this phase. But what I am saying is that you need to be aware and make sure you note these and talk to your doctors so they can give you the hormone test, they can give you the DEXA scans or the CAC scan for your heart and really understand holistically what's going on with you. So again, another big issue, and this impacts the older community, genitourinary symptoms, which is mean, things that are going on with our lady parts, basically. So it could mean UTIs, urinary tract infections recurring. It could mean incontinence, where you feel like you're going to pee. Many women think this is a natural part of growing older, and it does happen, but it is preventable. And we don't have to suffer through these things. And one of the best remedy for urinary tract infections and incontinence is a vaginal estrogen cream, which is safe for any woman with any condition, even breast cancer survivors or those with a breast cancer BRCA gene. So just there are things out there that most every woman can take advantage of. So going to the next slides, Stephanie, searching for answers and becoming the expert with yourself. These are the providers that I saw over time. Again, my eyes were failing, my bladder was failing, my lungs were failing. I had weird rashes and autoimmune conditions. I was later diagnosed with mixed connective tissue disorder, which is an autoimmune condition. And another interesting fact is most of the autoimmune conditions impact women, and a lot of them become exacerbated or come about for the first time in your 40s, 50s, 60s. So again, really, is that causation necessarily with low hormones? No, that hasn't been determined, but it is an interesting, it is an interesting fact that this is when this happened. It's a true statistic. So again, a physical therapy helped me, chiropractic therapy helped me, and the thing that helped me the most was estrogen replacement. They call it hormone replacement therapy. You may have heard HRT. That's hormone replacement therapy. There are many terms, but that's replacing the estradiol, the estrogen, the progesterone, and sometimes testosterone as well. Testosterone is great for low libido. Many women in their 40s and 50s start feeling that decline in libido, and they just think, well, that's my life. I'm not going to have a sex drive anymore. I'm not going to be intimate, and maybe their husband or partner, wants just the opposite. And again, that could be a lot to do with hormones. It could also be psychological, and maybe you need couples counseling and other things. But I don't want women to feel bad, like there's something wrong with them, because there's nothing wrong with them. This is a natural part of life, and you really just need to understand it and be aware of what's going on so you can do something about it. And however that looks for you, it could be getting on hormones, it could be seeing counselors, it could be doing some of these mind-body therapies that are discussed in this program quite often. So next slide, Stephanie, the leading causes of death in older women. We already discussed cardiovascular disease and cancers, respiratory. So I put that in there twice because it's important. And estrogen, low estrogen, progesterone are absolute factors in these conditions. And how do you help yourself? The next slide, Stephanie. Again, be aware, listen to yourself, and track this. It's so critically important. We don't want to be sick and dying from cardiovascular disease and cancers and Alzheimer's and dementia. And we can turn the curve on these statistics for women if we can become aware and advocate for ourselves and know what to ask our doctors about. And that's what I do with women. And I offer a free consultation, and I give you a planning sheet for free and lots of free resources on my website as well, because what I want to do is get the word out there, because it's just not, and I'm going to probably have a question for Dr. Kogan when I'm done with this, just on the knowledge across the board. And in medical schools, I know most of them are not training. They give an hour or two of menopause training. And again, it affects all women if they live long enough, and about 2 billion women are in perimenopause or postmenopause, right now. So knowing yourself and how to listen to yourself and then advocate for yourself. So next slide is talking about just that, preparing, advocating for yourself. But I'll tell you, it's hard. Even as a PhD, 30 years integrative healthcare, I did not know what was going on with my body. I felt really ashamed that with all of my training and experience that I had no idea that it was mainly hormones causing 90% of my health problems. And so I can only, feel for other women that have not gotten any information or training. So don't feel bad. If you didn't know this before, don't feel bad. Most of the physicians don't know this. They're not trained in it. It's not their fault. But we do need we need to do better with the health system in America. And we do need to do better for our women and our sisters and our daughters and our granddaughters coming up. So being one of all of those, it's important. How do you talk to your doctor? I'm just going to put this out there. Generally speaking, I was dismissed across the board by many physicians when I talked about my symptoms, like I'm not thinking well. Well, maybe you need an antidepressant. Or my mood and my libido is going to have a glass of wine, get out for a walk. I've really felt like I was being marginalized and dismissed by the doctors who were supposed to be listening to me and caring for me and really trying to understand. And low hormones is not a OBGYN concern specifically. It's a cardio doctor concern, a cardiovascular doctor concern. It's your rheumatologist if you have autoimmune conditions, it's their concern. It's, your orthopedics doctors if your bones are getting weak or your muscles are getting weak. We don't have any muscle specific doctors, and we lose so much of our muscles if we're not working them. So start lifting those weights or cans of beans, or straps and elastic bands. We can do some easy things to care for ourselves, but don't let your doctors dismiss you. Really step up for yourself, and there are ways we can do this together. Next slide, Stephanie. Budget friendly ideas. I believe that you guys talk about a lot of this stuff, making sure hydration, nutrition, enough protein. A fun one that I didn't really know about for your bones is jumping and having that bone impact. Jumping, jump roping, skipping are all really good, but just going to the gym and lifting weights, which everyone should be doing, or at least lifting weights if you don't go to the gym, is having impact on your bones in some way, because that helps the bone turn over and helps the bone grow and remodel. Otherwise, as women, especially if we're not any kind of hormone replacement, your bones will degrade. Men will, but it starts about 60, 70. It's much older and it's much more gradual. Women, it's just like a drop off. We have hormones, they start going a little crazy in your 40s, 50s, boom, they're gone on average, and then you're postmenopause. So that impact to your bone, really important. De-stressing, stress management. You guys have heard it all here. Breathe deep. And I'm going to go back to your journal again. Track your symptoms, because even for me, if I didn't have things written down in my notebook when I went in to see my doctors, I would forget what I was going to ask them. And I would lose track, or I would say one thing and the 10-minute, time period with them would be up for my appointment, and then I wouldn't get taken care of. So really, really write down, what's going on with yourself. So with regards to the underserved, lower income women who may be on Medicare, Medicaid, depending on your age and those other income factors, there are state offices on women's health that are just stepping up to start supporting women in perimenopause and menopause. You have your federally qualified health clinics, your free clinics. You have free resources like at the AIM organization as well. So there are some out there, and I have a couple listed here specifically for you to look at later, and they take Medicaid. I did research this. So those on Medicaid and or Medicare, there's two websites that do assessments for women in perimenopause and postmenopause. and they are the essentialmenopausecare.com and electrahealth.com, and they will take those types of insurance. So I think we're getting low on time, so I'm going to finish up. Next slide. Um, Stephanie, my goal is to help women thrive in midlife and older, because we are suffering much more than we need to. And we don't want to be on that path where, yeah, we're living longer than men, but we're in a worse state of health. We want to live long, we want to thrive, and we want to be as healthy as possible and as independent as possible for as long as possible. And my last slide is just how to get in touch with me, or if you have more questions. I have multiple YouTube videos that describe a lot of these conditions and my personal journey as well. And then I'm on Facebook. I'm giving updates on some of these conditions, where to find good resources. Instagram, if you guys are on any of those, that's where you can find me. But my website, drangmach.com, that's where you're going to get the free resources and information as well. So I will leave it open now for questions and answers. And I do want to finish, or at some point ask Dr. Kogan a question too.
Let's do a question now.
Okay, cool. So the question now is, do you know the training at all in medical school for perimenopause and menopause with regards to, medical student training?
Yeah, they get a standard training. I mean, they get it in preclinical and during the clinical. So preclinical, they have a standard women's health course, and then in clinical, whenever they work with GYN, it's obviously during the clinical, that's when it's important, and they're going to get very mixed training. So some of them that are really interested, they may end up in the very progressive GYN office and learn all the ins and outs of bioidentical replacement versus somebody else may get nothing really, right? They
Right.
may get just like, yeah, my GYN training was at the very shitty hospital in Freehold, Virginia, where I almost quit medicine because I observed delivery with episiotomy without anesthesia. And
Oh,
I called ombudsman, I called my dean, and I said, this is just insane. This was, safety hospital. And attending at 3 a.m. didn't want to do anesthesia for a woman. So, I had a horrible experience. That's actually why I didn't even consider going into GYN, because it's just, I had basically no experience. All I did is I retracted instruments during C-sections for 4 weeks. That was my entire experience of GYN. But I think things have progressed quite a bit since. So I think there's at least some training. Obviously, if they come to us and they rotate through the center, then they get a full experience with naturopaths who prescribe bioidenticals routinely. So.
right, right. All right. No, very good. And good to know that it's slowly progressing and getting more into the education as well, because it wasn't
Yeah.
from the
Right.
doctors that I'm talking with now who are, 40, 50, 60 years old. They didn't get the training. So I'm glad to hear that it is progressing,
Well,
with
there's
the
also long-time damage from the WHO study that was completely misrepresenting the reality, and it's the standard practice followed the WHO study for decades before finally now it's like, okay, sorry, we screwed up. But,
Absolutely.
that's
Yeah. The Women's Health Initiative in 2009 just scared the pants off of women that were getting hormones, off of doctors who were prescribing them. And now it's unfolded, like you said, that it was not true. There's some good information from that study, but no, it doesn't cause cancer. And that was the big scare. And the formulations of some of those hormone therapies are ones that we don't even use today. So
right.
it's kind of
Yeah,
moot.
it was very, yeah, it was very bizarre that they would basically say synthetic Premarin is basically identical. It's just,
Yeah.
it reminds me of the whole story how, the nutrients, even now, most of the nutrients are researched in their synthetic form, where that's not how humans consuming those nutrients, right? So it's our research tools are weak. That's all I can say. But
Yeah.
you got a couple of questions in the chat, and if you want to take a look yourself.
I cannot see that, but Stephanie, if you
Okay, so let me read you the one. Elva asking, "What about jumping on trampoline?" I think it's a great question. And actually,
yeah,
funny thing is, my wife just bought one, and we're assembling it. So we have a
yeah.
little trampoline to jump at home.
So trampoline is good for so many things. It's good for blood circulation, for your lymph circulation. So you have these glands and they don't get, pumping like vessels and hearts and things like that. So it's really great for getting your lymph and your glands worked and your blood flowing and some exercise. It doesn't do as much for your bones, if anything. So your bones kind of need the hard impact. So if you're going to do jumping jacks or skipping, kind of land a little bit hard. Now, if you have bad knees or other problems with your joints, you don't want to do that. And this is probably way out there, but NASA astronauts use these vibration plates after they come back from their trips because their bone density gets very low, the astronauts, and in order to get their bones healthy again, they get on these vibration plates as therapy, and then their bones will start to remodel and work again. So in worst case scenarios, and again, this is something you'd have to afford out of pocket, insurances aren't paying for it to my knowledge, is to get a vibration plate, but do your research because they make them all different. They have to be a certain megahertz and vibrate it a certain way. But I tell people that have really bad joints or they just can't do that impact, let's see if we can find a low cost vibration plate and do that for your bones. But no, that's a great question. And another thing around osteoporosis, which means you have very low bone density, that can be reversed because I was diagnosed with osteoporosis at 55 years old. And I had always exercised and gone to the gym and ran and triathlons, all the things, ate right. And I was diagnosed with osteoporosis within 10 months of being on therapy and starting more of the impact exercises. 10 months started to reverse my osteoporosis. So the good news is it's reversible. If not, when you're older, you can stop the breakdown with some of these therapies and exercises. So, no, great question.
And the second question I'll probably answer quickly because it's more of a frequency of the DEXA. So Medicare actually does not allow annual tests anymore unless they order it in a specific way. So that's the question that Cecilia is asking about frequency of DEXA scans. Cecile, the amount of radiation that the DEXA gives you is nothing. It's something like 10 times less than one single dental X-ray. It's about the same as when you go through the airport security. It's not considered of any consequential harm whatsoever.
Mhm.
Versus mammogram, by the way. Mammogram is a lot of radiation. The mammogram is 1/10 of a CAT scan. It's actually quite a lot. It's equal to about 20 dental X-rays. So that we reviewed this. If anybody's interested, go to our YouTube channel at the CIM YouTube channel, and there's a whole video on amounts of radiation from various tests and what this contributes and how you need to think about this.
Yeah.
And so Cecile, the DEXA, once your bone density stabilizes, the frequency of DEXA scans should really be discussed with your clinician. I don't necessarily follow them manually. I follow them manually when we're aggressively treating because I think the frequency at that point is more important. Once things are stable, sometimes you don't even have to do them every other year. So it really depends on a specific situation.
And I would like to add also, if you haven't had a DEXA scan, get one because the sooner you can get a baseline on your DEXA and you know where you are. Because if you're a woman who exercised a lot in your younger age or you didn't have regular cycles, your bones could already be very low, and we need to start looking at how to remediate that and get that fixed. So, if you've broken a bone in your past or your mom or your family has a history of osteoporosis, those are two things that you could tell your doctor. If they don't want to cover it, if they say your insurance won't cover it, say, well, I've broken a bone before, I'm at risk, or my family has a history of osteoporosis. Usually one of those two things will get them to order it and then it'll be covered by insurance. But the earlier you can, the better. I wish I would have gotten one when I was like 40, 45 to at least have a baseline because I would have been doing things so much differently, at 40 versus 55 when I got the DEXA. And I knew at that point I was shocked to know I had osteoporosis. My bones were, yeah, getting weak.
Well, Angela, thank you so much. There's information for everybody in the chat. If anybody's interested in scheduling a quick consult with Dr. Ang, please contact her. And Stephanie's going to do our little mindfulness today in the last couple of minutes.
Well, thank you so much. I was just going to share a practice that we've done here before, the 4-7-8 breath. which is great for just sort of de-stressing, helping shift our body from fight or flight into more rest and digest state. This was developed by Dr. Andrew Weil, a friend of ours here. And one of the primary parts to keep in mind as we practice this is the placement of our tongue in the mouth. So we will start with an inhalation through the nose quietly to a count of 4, and then holding to a count of 7 and resting the tip of our tongue on the roof of our mouth, and then exhaling audibly through the mouth to a count of 8. And it's specifically that extended exhalation that helps sort of downshift our nervous system. And this is a really great practice if you deal with anxiety or panic attack. I like to do this sometimes too if I have trouble falling asleep. Helps quickly quiet the mind, shift our body, just in 3 or 4 rounds. It's very grounding. So we'll all just meet together. You're welcome to keep your eyes open or lower your gaze or close your eyes. And just take a moment to settle in. You're welcome to take one hand to your heart, one hand to your belly, and just observe how your body is in this moment. Observe maybe the rise and fall of your belly as you breathe. Notice our ribs expand and contract as we breathe as well. And then in your own time, I invite you to breathe in through the nose to a count of 4. And holding at the top again, holding the tip of your tongue at the roof of your mouth. Holding here for a count of 7. And then exhaling through the mouth to a count of 8. And you're welcome to make just like an audible sound, just exhaling any tension, stress that you may feel. And again, in this way, an inhalation to the count of 4, holding for the count of 7, and exhaling to the count of 8. And we'll do 3 rounds here, just in your own time. And pausing here, just observing the dance of sensation. noticing anything that has shifted. And just taking a few moments to tune in and pause. And whenever you're ready, you're welcome to float your eyes open. Thank you so much, everyone. And I'll share in the email that goes out as well. I just have a little fact sheet about 478 breath, as well as a video that you can play. It's a 5-minute guided practice. It's nice to kind of just have in your toolkit.